In the phase 3 Beacon trial, we compared a new formulation of irinotecan called irinotecan pegol that has a more standard exposure in vivo than non-pegylated irinotecan. This drug has shown some benefits in phase 2 in breast cancer before. The randomized Beacon trial compared irinotecan pegol to treatment of physician choice with a set menu of agents. And the primary endpoints, of course, in this trial looked at overall survival. And although we did see a benefit in some populations of patients treated with irinotecan pegol, and we saw a benefit in those with CNS metastases at baseline, overall the trial endpoints weren't met, benefits in overall survival and progression-free survival also. We've been trying to look at what population of patients might particularly benefit from irinotecan pegol. This population in the Beacon trial had received multiple lines of prior chemotherapy, so they had highly resistant disease. We were very interested in circulating markers of response or resistance, and so we planned to look at circulating tumor cells in these patients. And actually, we received blood at a central quantification facility in a large number of patients treated on this international trial, which I think already shows the feasibility of doing blood markers in this kind of phase 3 multi-center trial. And then we analyzed the CTCs that were informative. There you get into smaller numbers. And what we found was that an early change in topoisomerase 1, which is the target of irinotecan pegol and of course irinotecan as well, predicted overall survival benefit in these patients. Now, this is a subset hypothesis generating analysis, but it suggests that we may be able to use early response indicators in the blood to help us understand who are the population of patients who are most likely to benefit from specific treatments versus our standard, because of course this was comparing irinotecan pegol versus the standard therapy. Now the caveat here is that a CTC analysis is complicated, there are small numbers in the circulation, and the ability to then look at markers in those CTCs occurs in a still smaller population. It may be that circulating plasma DNA from tumors will give us an even better indicator in the future. But I think we've really seen exciting data that suggests that blood markers may allow us quick turnaround, an early marker, as opposed to doing serial biopsies of tumor in patients with metastatic disease, where we may or may not get enough tumor in the actual biopsy. That's a huge issue. They may or may not have tumor that's safe to biopsy, and there's always trauma associated with biopsy as well as risk. So if we could get this information from the blood in the future, it's going to really change the way we do clinical trials and hopefully remove the patients who are unlikely to benefit early and decrease the number of patients that are required in a clinical trial to reach an appropriate endpoint.